Mike Gibson, Steve Nissen coming to you live from AHA 2024. Steve, it's publicly known I have an elevated LP(a). I'm looking for drugs that'll knock it down. You're leading the charge here with yet another molecule, a small inhibitory RNA. Hard for me to pronounce it. I know you'll help me here, but you just are presenting data on 60-week follow-up with this drug to knock down people's LP(a). Talk to us about what you found.
Yeah. Well, this drug is called Zerlasiran. It's being developed by a company in the UK called Silence Therapeutics. And I think, as most people know, this is a genetically determined disorder. And in order to lower lipoprotein A levels, the primary approach now is to inhibit messenger RNA for apolipoprotein A, which is the rate-limiting step in assembly of lipoprotein A particles. This drug we studied in 5 different dose groups, 2 placebo groups, one every 16 weeks and the other every 24 weeks. Zerlasiran, 300 milligrams every 16 weeks for 3 doses, or either 300 or 450 milligrams every 24 weeks for 2 doses. And the primary endpoint was the reduction in lipoprotein A. The people that we enrolled were average age of in low 60s. About 3/4 were men. Their median LPA levels were around 220 nanomoles per liter. They were well controlled with LDL levels of around 70. These were all people at high cardiovascular risk. The key result is that we measured this time not just peak effect, but time averaged effect. We wanted to know what the effect was to include both peak and trough levels. And over 36 weeks, with all 3 regimens, we got anywhere between 80 and 85% knockdown in lipoprotein A levels. Also, interestingly, we lowered LDL cholesterol by about 25 to 30%, and apolipoprotein B by about 10 to 15%. Those 36-week results were persistent at 48 weeks, 80 to 85% knockdown, same effect on LDL. Out to 60 weeks, a little bit less, high 70s for lipoprotein A reduction. If you look at the patterns of reduction, we saw something interesting and I think important. With each successive dose, the trough and the peak levels went lower. For example, with 300 milligrams every 16 weeks, the trough was 65.7%, but then 16 weeks after the second dose, it was 80.7%, and 16 weeks after the third dose, it was 83.2%. What does this mean? It means the effect of these small interfering RNAs has a cumulative effect with each successive dose going to lower levels. We also are showing waterfall plots that show that, particularly when given every 16 weeks, the 300 milligram dose had a very consistent effects, with the vast majority of people staying in that 80 to 100% reduction. And so it seems like everybody responds very well. Importantly, in phase 2, this was a 180 patient phase 2 trial. So in phase 2, you always want to look at safety, and we really saw essentially nothing. Some mild injection site reactions, nothing really of any significance. So we conclude that this small interfering RNA, when given every 16 or 24 weeks in doses ranging from 300 to 450 milligrams, can lower LPA time averaged by 80 to 85% over 60 weeks, can lower LDL 25 to 30%, and can lower ApoB by 10 to 15%. There is an important take-home message here, which is now that we're approaching effective treatments, we have to identify these patients. And so we have a very strong message to clinicians. Start measuring lipoprotein A routinely, particularly in ASCVD patients and their families. The manuscript for this study is in JAMA. It was available online at the time of presentation. We encourage people to read it and get the additional details about what we did.
Well, Steve, just amazing work. My grandfather had a heart attack at 45, and so I have a family history, and I've been trying to educate people just like you to get your LP-little-A checked. I didn't know I
Yeah.
had an elevated LP-little-A. I had an LDL of 70. Thought I was good, but my LP-little-A was very, very high. So people need to know about this risk factor. Tell me this, Steve, are the other agents in this class, do they also lower LDL and ApoB, or is this unique to the molecule? And is this like a poly shot with multiple effects rather than just an LP-little-A drug?
They all seem to lower LDL and ApoB, but there may be some differing extents. Now, populations are a little different, so they're probably the same. The mechanism is interesting here. Keep in mind that lipoprotein A is an ApoB covalently bonded to ApoA. If you lower lipoprotein A, you're going to lower ApoB because of the way we measure it. And so, is it a bystander? Does it contribute to what we hope will be event reduction? Stay tuned. We don't know the answer to that yet. We hope it does, because if we can lower lipoprotein A, which we know is pro-atherogenic and pro-inflammatory and probably prothrombotic, and if we can also lower, ApoB and LDL, then maybe we can get a magnification of the benefits. That's certainly what we hope. We are going to have the results of the first of these trials, the outcome trials, the big outcome trials, within the next couple of years. So for those patients that have this, help is on the way.
Thanks so much, Steve. People like me are anxiously waiting. It's great to see we have a surrogate, that the drugs improve the surrogate. We'll see if it improves outcomes. I'm hopeful and optimistic. Steve, thanks for sharing with us, and thanks to all of you for dialing in.
And I'm optimistic as well, and thank you for having me.
Thanks.